Right. Now, good afternoon, Mr. Stephen.
Good afternoon, my lord. This afternoon we're expecting to hear from Fiona Loud of Kidney Care UK, and this witness is going to be giving their evidence remotely.
So I see, actually. Good afternoon, Miss Loud. Can you hear me all right?
Good afternoon, my lord.
Oh, you can. That's good. Splendid. Right, you're going to be asked some questions by Mr. Stephen when you're ready, Mr. Stephen. Thank
you, my lord. And for the record, the witness statement inquiry reference number for Miss Loud is SCI-WT 0426-01. Firstly, Miss Loud, can you see and hear me okay before I start?
I can. Thank you, Mr. Stephen.
Good, thank you. Could you confirm your full name, please?
Yes, I'm Fiona Caroline Loud, and I am Policy Director for Kidney Care UK, the patient charity.
Thank you. Your age and contact details are known to the inquiry, so I won't ask you for those. And you've already helpfully provided a witness statement. Can I just check that you're content for that statement and the oral evidence that you're giving today to constitute the evidence that you would like to be before the inquiry?
That is correct, thank you.
And are you happy for that evidence to be recorded and published?
Indeed I am, thank you.
Okay. Now, I'll say at the outset that everything that you said in that statement, even if we don't touch on it today in oral evidence, will be taken into account by the inquiry, and I will also give you an opportunity at the end if there's anything that you think that I might have missed to pick up on then.
Thank you.
And finally, before we move into the detail, just to remind you, there is a restriction order in place, so please do not name any other individuals when you're giving your evidence. If you're referring to a staff member, refer to them as that rather than name them specifically. Is that clear?
It is, and thank you for that.
Great, thank you. Now, I think you said already, but your role is Policy Director at Kidney Care UK, is that correct?
Yes, indeed.
And how long have you held that role for?
I've been since 2013, summer 2013.
Okay. And what does that role entail?
So that role entails taking all the information and the evidence we receive from people with kidney disease and using that to campaign for better treatment for people with kidney disease. Thank you.
Prior to that, you were Director of the Kidney Alliance, I think you say in your statement, which was representing kidney charities across the UK. Is that right?
That's right, yes. So that was a number of patient and professional charities across the country.
And your previous professional background was?
My previous professional background was in IT, where I was originally a programmer, and then a project manager, then a people manager.
And how did you come to be involved then with kidney charities?
I came to be involved with kidney charities because of what happened to me. So while I'm Director of Policy for Kidney Care UK, I'm also, I have life with kidney disease, and I had to stop work for a number of years because I suffered kidney failure. I have a genetic condition, and I spent 5 years on dialysis before receiving a transplant from my husband, I probably can name, 17 and a half years ago.
So you bring that lived experience to your role then as Policy Director?
I do indeed, yes. And many of our staff are in a similar situation, although not necessarily all of them.
I want to ask you now about the organisation itself. The organisation you're representing today is Kidney Care UK. That's a kidney patient support charity.
That's right, yes. We're a UK charity. We used to be known as the British Kidney Patient Association, but we changed our name in 2016. We still do the same things, though. We are there to support everybody with kidney disease and their families too, so that they are able to be supported in all aspects of their life, which aren't the NHS.
And that's a UK charity, so registered both in England and Scotland?
Yes, we are registered in Scotland as well as England.
And therefore your organisation offers services across the country, would that be fair to say?
That would be fair to say. We offer counselling, we offer patient support and advocacy services, and we offer all of our other grant, financial and information support services everywhere in the United Kingdom.
And in terms of the size of the organisation then, just to get a clear picture, how many staff does Kidney Care UK have, and what's the sort of geographical spread, if you like?
Yeah, we have about, I think it's about 77 people now. When I joined, there were 10 of us, so you can see the organisation has grown. And not all those people are full-time, though. Some of them are part-time. And in Scotland, I was just counting just now, we have 5 members of staff, we had 5 members of staff.
And I suppose breaking those down slightly further, your statement refers to, I think, patient support and advocacy officers as well as counsellors. What are their respective roles?
So our patient support and advocacy officers, who are throughout the whole of the United Kingdom, their roles are to support people locally with any of the questions or queries they may have about their conditions. So that could include assisting them with getting benefits, going to a tribunal with them if they need further support. It could include helping them to make a case with some issue on housing, for example, or it could include advocating for them around things to do with treatment or employment, for example. So a wide range of things that people who are affected by kidney disease, and especially late kidney disease and kidney failure, may need further help with. They can also help to direct them towards our grant services or our counselling services.
Thank you. And in terms of, I suppose, the size of the task that you face, I'd be interested to know, for the population of Scotland, for which this inquiry is obviously principally concerned, how many in Scotland, if you know, are living with chronic kidney disease, for example?
So, I mean, across the whole United Kingdom, we estimate there's about 7 million people living with kidney disease, but that's at all stages. In Scotland, the estimate is about 607,000 people with all stages of kidney disease, looking likely to rise over the next few years. Of that number, about 273,000 have the later stages of the condition, which is often referred to as sort of moderate to advanced kidney disease. So, a large number of the population.
Thank you. Moving on then to the impact of the pandemic upon your organisation. I think you note in your statement, I think you marked at the beginning of the pandemic by reference to a parliamentary event that was due to take place. I think it was World Kidney Day. Is that correct? On the 12th of March 2020?
That's absolutely right. And in fact, in a strange irony, tomorrow is World Kidney Day 2024. So yes, for World Kidney Day 2020, we had an event planned at Westminster, and that was a day at which we realised we couldn't possibly go ahead with that. And we had to call up all the patients that were going to be attending and tell them not to go. And that was the day I personally decided that I wouldn't be going out anymore, because it became obvious that the risks to people with kidney disease was just growing by the minute, and we didn't know how much it was, but we just had to be really, really cautious as we started to see the pandemic was beginning to spread.
And I think you yourself say in your statement that you were immunosuppressed, so you had to stop working.
Well, I carried on working, but working from home, yes. Yeah. So that's when I say we stopped, I meant myself as well. So I think the 12th of March is probably the last time I went out for a long time, because so some people, like myself, who are immunosuppressed, because that stops your precious donated kidney from rejecting from your body, you have to take tablets to stop that. They're called immunosuppressants, and they give you a greater risk of catching infections, so you always have to be aware of that risk, but with a new and unknown risk to people like us. I certainly got home that night and said, that's it, I work from home from now, and I didn't go back out again for months and months.
And what changes did you have to make as an organisation to your ways of working in light of what happened with the pandemic?
So, Mr. Stevens, so what we had to do was we had to rapidly deploy our members of staff home. We had to buy laptops for people. I already had one because I moved around the place quite a lot for my job anyway, but we had to buy laptops for all of our staff, including our admin staff, who would have normally used a machine in our head office, which is in Hampshire, and then effectively closed the office down, although we did, of course, leave room for the post, and someone would come in from time to time to check the post. But we had to completely change the way in which we worked and how we talk to people.
And I think crucially for a charitable organisation, what impact did the pandemic have in terms of your fundraising?
So much of our fundraising, in common with many other charities like ours, will include community events. So people might choose to say, we'd like to raise some money for you to help your counselling work, your advocacy work. And that might be cake bakes or the London Marathon or something else like that. And of course, all of that had to stop So for our fundraising team, in common with many other charities, that was a real challenge, and they had to get very creative to think of other ways to do that, because I should say that patient demand increased enormously because of people wanting advice, people feeling very anxious, and many other things about the incoming disease and what that would mean to them. But we had to get very creative in terms of thinking of other ways to do things, and things that people could do in their back garden and running up and down the stairs, or other such events to raise funds and awareness for the charity.
Thank you. And given what had happened as regards fundraising, what was the impact upon staffing in the charitable sector as a whole? We can come on to kidney care specifically, but what did you notice generally about staffing as a result of what was happening with fundraising?
So generally across the charity sector, I noticed that some charities had to make quite a difficult decision, which was to let some people go. I can't tell you who all those people were, because that wasn't what we did, but I did notice that, because of course a number of people would be involved with really actively helping with those fundraising types of events. And so I did notice that in terms of a change in the way some organisations worked. But then some, like us, deployed to the front line with providing information, continuing to provide telephone services and other ways of counselling. And we all adapted very quickly to using initially Zoom, but also Teams.
And did your organisation lose any staff or make use of furlough, for example?
I don't think we lost. I don't think we had to let anybody go. But I mean, during that time, a couple of people did leave anyway, just through natural attrition, and we had to use furlough for not that many people. I mean, perhaps 3 or 4 people, I suppose. I can't remember the exact numbers now, and for part of that time. So those would have been people perhaps who had young children who needed to stay at home, or were sharing care with their partners as well, so tried to do a bit of, continue some work, but also have to take some time in furlough and use the government scheme to support that.
And I think you also say in your statement that you tragically lost a colleague, was the chair of your organisation in around March 2020, is that right?
Well, we actually lost 2 colleagues, in fact.
Doesn't appear
Do I
so.
have to press my button? Or
Mine's on, and
mine, I think, is on. Can you hear me, Miss Loud?
Yes, thank you. I'm back.
No, not at all. We have taken, you, as you appreciate, inadvertently, I'm sure, mentioned the name of the late director
Yes.
of your organisation. We have excised that from the record being kept, and we've told the people in the room that are listening that they mustn't repeat that. So I appreciate fully it wasn't your fault. Easily mistake made.
Apologies, my lord.
No, not at all. Not at all.
Start that again, and I'll just not use any names.
Yeah, thank you. Mr. Steve.
Thank you.
Thank you, my lord. And Miss Loud, can you see and hear me okay before I start asking questions again?
Yes, thank you.
Good, thank you. I'll move on if I may. I wanted to ask you now about just the topic of guidance, actually, in the context of moving activities online for your organisation. I think you described in your witness statement the organisation's website becoming the most important window into what the organisation was doing, and also that you became a leading source of information on COVID. How did that come to pass?
Yes, so as I explained, we deployed home very rapidly, and we realised from the volume of questions that we were getting that people with kidney disease, and that included people at all stages of the disease, had many, many questions, and they wanted to know what was happening, what should they do, where should they go. And we rapidly got to work with colleagues, medical colleagues, and pulled together our first page of information, which just explained that there were some risks to people with kidney disease from COVID that we didn't know much yet, and that it would be advisable for people to stay away from others if they possibly could, and started to create a kind of a set of things that people should consider as they went about their business or didn't go about their business. That included defining who might be at the highest level of risk. So if you were at a later stage of kidney disease, if you had a transplant, if you were on dialysis, which is an option for some people to keep them alive, and so it's a form of treatment. And so we listed out all of those things as clearly as we possibly could and published them online. We realised that people found that information very valuable, so we made it our business, particularly myself and my colleagues in our policy team, with medical colleagues, to put together the best quality of information we could. So partly informed by what was going on, partly informed by what government or the various NHS organisations were saying, and partly informed by the many questions we were receiving through our helplines, social media, emails and so forth about what to do and what risk people were under. So that information grew and grew, and it became nice, and then the SMC, Scottish Medicines Consortium, went on with that as well, recommended it as a good place for people to look if they had questions about chronic kidney disease or kidney disease overall, and COVID-19. And we must have updated it, I can't remember, sometimes it was twice a day, depending on the new information we got. And if you can imagine, gradually the information started to build, but sometimes information would come from NHS or governmental sources, and it didn't necessarily apply to people like us, people with kidney disease, or it needed a greater level of understanding to put it into lay terms. So that was the point at which we might have to embark on a conversation with the relevant health department, government department, or doctors, nurses, whoever, to understand what that meant in terms of people with kidney disease. And it was called it sort of a labour of love after a while, because it just grew and grew. And in fact, just yesterday we updated the information again, so we still have that as a live source of information. Now it's all about the next vaccines, reminder what you do if you get if you do get COVID, and what treatments are available to you. But at the very beginning, we were just starting to put together the range of advice and of guidance that might be there for you. At the very, very beginning, people didn't know very much at all. So it started sparsely, but it grew and grew and grew. And the quality of it was hugely improved by our readers, our contributors, and of course all the teams at Kidney Care UK combining to get that published as regularly as we could. And we also know that our readers liked it because they told us all the time, and they also pointed out if we made a mistake, got the day of the week wrong or something like that. And that was both a challenge, but really motivational as well, because it made us work as hard as we possibly could to give the best quality of information you can, because in an information desert, and I know it's a bit of a theme of our submission, is that we didn't feel the communication was perhaps as clear as it could be to the many people with kidney disease about their risks and what they could do about that and what treatments would be available to them, if any, through the pandemic.
Thank you. Yeah, I mean, as a UK charity...
Could you, just before you go on, Ms Stephen, you mentioned in the course of that rather long answer, Ms Lund, NICE, I think that's the National Institute for Clinical Excellence, is that correct?
That is correct, yes. And NICE worked with the SMC, the Scottish Medicines Consortium, to produce some rapid guidelines on COVID-19, which we input to as well. And that was the reason I referred to that, my lord, was that they actually named at some point our information as being a good place to refer people to for the latest up-to-date information.
No, I just wanted to get the acronym into the record. Sorry, Mr. Steele.
No, I'm obliged. Yes, Ms Loud, you said earlier, of course, it's a UK charity, the organisation, and you're providing services across the UK. You also mentioned in your answer there the number of sources of information on guidance that you were receiving and having to act as a conduit for, I suppose, for want of a better word. I wanted to ask you just the question, how straightforward did your organisation find the task of providing this information on COVID to those with kidney disease, kidney issues?
So I do have to say that it was a challenge, trying to pick our way through the information as it appeared, or ask the questions to try to get to the right information. And it, as I said, it literally started with who should be on the shielding list, or as it became known in Scotland, the highest risk list. And that's where it started, to try and understand which people with kidney disease, was it all stages of kidney disease, was it people with transplants, was it people on dialysis, was it all of those? Because if you were at that point on the list of people who would be advised to shield, there were certain things that would go with that to provide you with a level of protection, although albeit the protection was partly provided by just staying in your house and not going and talking to anybody else or seeing anybody else. So it was quite the challenge, and to deal with the different nations and the fact that information came out at different stages from the different nations as well was also quite challenging. So in Scotland, sometimes we had to get the information from England and then understand whether the same information would apply in Scotland. But likewise, sometimes Scottish Government would volunteer, once we'd made our links fully with them about this, would then give us some information that was coming here in Scotland, and how it would apply to people in Scotland as opposed to the rest of the country. So we would, within that information source that I've just described, that grew legs and then had to be rapidly reorganised to become easier to read, we would say, here's this announcement about shielding or tiers or something like that. In England it's like this, in Scotland it's like that, in Northern Ireland and Wales, so on, so that people in each of the nations would get the generic information about perhaps stay isolated, do some shielding, but then the specific information that may apply to the different, may apply in Scotland about, as time went on, where you could travel to, how far you could go away, which tier you might be in, and so forth.
You mentioned shielding, and we'll certainly come back to that in due course. I think you also said in your witness statement on the subject of guidance that you conducted a number of surveys of those that users of your services. And I think the phrase you used at paragraph 54 of your statement was that people didn't know where to look. And I think you also make the point about a difference in perhaps terminology between, say, England and Scotland. Is that right?
Yes, that's right. We ran 3 different surveys through from probably for about a year, 2020 to 2021, and we received 2,500 responses overall. And through those surveys, one of the key things was about lack of communication. There was information about mental health support, which I can come on to as well. But in answer to your question about lack of communication, people did not know where to look, because if they hadn't received a letter directly or an email communication, which at first nobody received anything for a period of time, they just knew that this thing was there, and it became obvious, and I can explain why in a minute, that people with kidney disease would be quite vulnerable to the condition. They knew they were worried, so they started to look about the place. They asked their doctors, they would ask their kidney consultants, and of course they would ask a charity like Kidney Care UK, what do I do? What should I be doing? And it was quite the challenge to get that information to people in a way that they could understand, that they would know what applied to them and would be able to take a sort of informed, risk-based assessment about what they could do. Would it be to shield completely, to go to work, and for how long should that apply? And also, what should members of their family do as well? Because we're all individuals who are, people, not just people with kidney disease, but we have families around us as well. So we had a lot of questions about what should people see their families? Should they see their grandchildren? Should they give them a hug? All of those sort of questions. So some of them were very, there's a lot of emotion in that, as well as just trying to see through the facts and the news as it came up and work out what did that mean to me. And that was something we felt through our information. It was something we should try our very hardest to be able to produce, but also to challenge different authorities to make it as clear as possible. And as you say, Mr. Stephen, having different terms in different countries at certain times made that quite difficult.
So is there, do you think, a lesson learned there, looking back on what you've just said about different tiers, different approaches taken in the 4 nations, et cetera, and given what you've just said just now on terminology, do you think there's a lesson there?
I think there's a lesson about communication. I think there's a lesson about working with charities like ours who are very close to the population, if you like, specialists on the people that we're working with and representing, but also a lesson about consistency, because if someone is listening to the main news, they might hear one term that only applies in that country and a different term in the other country, and the different tiers. And in fact, when I was going back all through all this for today, I thought, I can't believe we used to have all these different levels and tiers and things, because I'm sure it made it more difficult for everybody, whether it's public services, provision, medical provision, that we had so many different kind of strategies, and there was a bit lack of consistency around the place. So I think it would be a very helpful learning from the very difficult things that happened in the pandemic to try to adopt some levels of consistency in terminology, and to invite charities such as ours, to work with on the communications. And that, I should say that, that did start to happen, but I think it could have been a lot more timely and made easier with a little more notice and a bit more involvement about what does this actually mean to somebody affected by this directly.
Thank you. I move on now then to ask you about the impact of the pandemic upon those with kidney issues at that time. But first, prior to the pandemic, how would you expected those people with developing kidney disease to have been dealt with? And you touch on this in paragraph 70 and 71 of your witness statement. What would have been the status quo prior to the pandemic?
So prior to the pandemic, if somebody has, well, first of all, if somebody has high blood pressure or diabetes, they should be getting an annual check, and that annual check should include a kidney check. And so that is one of the ways in which somebody with chronic kidney disease would be identified. And if that person's kidney disease was then seen as going down, deteriorating, they would then be referred to a specialist hospital where they'd be seen by a kidney doctor, and then over time perhaps left in primary care or maybe stay with the hospital, and if they were unfortunate enough for that to be genuine kidney failure, they would then be taken into specialist care, as in looked after by their hospital for more of their appointments, and then eventually they may have to go onto dialysis, the transplant list, or be fortunate enough to get a transplant, or some people may pass away before either of those options were relevant to them.
And would you have expected those people to have been given a choice, for example, as to the form of dialysis and the place of dialysis, if that was required pre-pandemic?
People should. Well, first of all, they should be picked up in a timely way, so they decline, if there is a decline that can't be addressed, should then have those choices, absolutely. And whether that is dialysis at home, whether that is dialysis in a hospital, and whether it's dialysis through your tummy or through your arms, there's different ways to receive that dialysis. But I would emphasise that it's a life-maintaining treatment.
So during the pandemic then, I think you observe in your witness statement, paragraph 79, that it was safer to have dialysis at home during COVID, but there was a problem with the obtaining of the surgery to enable people to have that. What was that problem? Could you explain that? So
yes, vascular surgery. So in order to get the dialysis at home, you would need a level of surgery in order to have the access in your tummy or the access in your arm to the dialysis treatment itself. And so trying to get those surgeons to be able to give those choices, some of that was a challenge as well. So that's what I was referring to there, is that while home dialysis would have been safer because you had less need to go out to the hospital. So just to contrast that, if you're on dialysis, that would be 3 times a week in hospital for sort of 4 to 6 hours at a time with a journey there and back again, whereas dialysis at home, of course, would involve less exposure to other people. And so there was, as with all the things that I'll be talking about, there was a bit of variation on where and how you'd be able to get that access to that surgery. So it wasn't entirely clear to us what happened with home dialysis, apart from the fact that there was ultimately a lower level of COVID-19 in people at home, and so that choice may have been affected, as indeed would have been the numbers of people approaching dialysis or being picked up sooner, because they would have needed kidney care for their kidney failure sooner, but perhaps weren't picked up as soon as they could have been because of the impact of the pandemic.
So if I've understood you correctly then, if people were still apprehensive about visiting healthcare places due to COVID, you make the point that those needing dialysis would have had no choice but to go to the hospital, and the consequences of that, if they didn't, would be fatal, would be renal failure. Is that right?
Well, that's right. Yes, if you have kidney failure and your kidneys have actually failed, dialysis is life maintaining. So you do need to maintain that treatment on a regular basis. And
are you aware of, if you know, how many people died through COVID that were receiving dialysis, that were having to visit hospitals? Do you know the answer to that?
Yes, I do have some numbers on that. I'm just going to refer to one of my papers, if that's okay, because I've got to get the numbers right. So, okay, so in the first, between the 26th of March and the 14th of April, the UK Renal Registry received notifications of 1,173 positive COVID results from people on in-centre, that's in-hospital dialysis patients. That represented 5% of the total population on dialysis. And this is a published report from the UK Renal Registry, and as it says, it is very sad to report to you that the 7 and 14-day mortality at that time was between 11% and 19%. So you can see that was, in those early days, it was quite devastating for people with kidney disease. If I may add to that with permission, that was across the whole of the UK. I have just pulled out some specific numbers from the Scottish Renal Registry for a slightly different period of time, which was up to the 22nd of September. I think it was I'll give you the earlier date in a moment, and they reported 120 cases with 30 deaths. So
states are all in 2020, I take it?
That's all in 2020, yes.
Okay. And thank you for the clarification as regards Scotland. As you're aware, our remit is obviously looking at the Scottish Government's response to the pandemic.
Yes, that's right.
Can I ask you also whether the pandemic had any impact upon the frequency of which people were receiving dialysis?
Indeed. So in some hospitals, but I would say that not so badly in Scotland, but in some hospitals there had to be a restriction in the amount of dialysis people could give, and some people were moved to twice a week dialysis rather than 3 times a week dialysis because of the ability to care for everybody, to provide adequate isolation for those who were COVID positive, who had to be moved into different units, or segregated, if you like, to COVID positive and COVID negative people undergoing dialysis. So therefore, for some periods of time across particularly 2020 and then again in part of 2021, some people had to receive less dialysis than would have been ideal. But I do have to say that in Scotland, I don't have a note of people that happened to them in Scotland, but overall that was not a great experience for some people on dialysis.
I think you also talk about in your statement about the delivery of home dialysis equipment. How, in your experience, was that affected by the pandemic restrictions?
Yes, I do indeed. So if you are dialysing at home, you would need to receive regular tubes, boxes of fluids, lots and lots of reusable stuff, and that would have to be delivered to you. So in a couple of cases that were reported back to us, but I can't tell you where in the United Kingdom that was, because we heard from very frail patients who said that the delivery drivers were not prepared to bring the equipment into the house. So that caused them a problem, which we had to speak back to the dialysis company manufacturers and delivery agents about trying to get all of that heavy stuff into somebody's house in order to provide a level of assurance for the drivers, but also for the patients who would be anxiously waiting for all that equipment, because if you don't have your renewables and your supplies, you can't run the treatments.
You also touch on the issue of procurement and the availability of equipment in your statement at paragraph 110. And I think the phrase you use is it became a huge problem. Can you explain why that was an issue?
Yes. So alongside the existing population of people who are dependent on dialysis to stay alive with kidney failure, COVID-19 had a nasty effect on as well as on the lungs, on the kidneys of a number of people who had COVID. Again, just to be clear, this is in 2020, so it's building up sort of March, April 2020. And in fact, some of the data shows that 28% of people affected by COVID needed dialysis, mostly in intensive care units. And what that meant was that there was quite a stress on the materials. I just talked about the materials for home dialysis. Well, these were the materials that the hospitals would be using to deliver their dialysis. And there was a global demand for these products. In fact, a note I have here is that global demand for those products tripled as the pandemic really took off in Italy and in America, New York particularly. I remember at that time, and because of that lack of equipment, Kidney Care UK raised that with the NHS very, very urgently, and eventually, after a couple of weeks, a decision was taken for procurement and distribution to be made across the whole of the United Kingdom, because otherwise there could have been a situation where Hospital A was in desperate need, ordered all the stuff, and then by the time you got to Hospitals B or C, there wouldn't have been anything left for them. So by introducing a national procurement and distribution system across the United Kingdom, the equipment was able to be shared appropriately across the country so that nobody would actually lose out. And some new protocols were put in place as well, and some additional training for staff, so that they would be able to provide the type of dialysis necessary for people who had acute kidney injury, which is when your kidneys suddenly go down and you very quickly need dialysis treatment. That is different to when your kidneys have failed as part of your chronic kidney disease over a longer period of time. But as I said, COVID-19 had that particular effect on kidneys, particularly at the beginning, and it really did need additional level of dialysis treatment to keep people maintained in the intensive care units. So that was something that we were both extremely concerned about, but wanted to be able to give reassurance to people who were actually on dialysis for their persistent chronic kidney disease, that their supplies wouldn't be affected by the fact that additional equipment or similar equipment is needed for people with acute kidney injury exacerbated by COVID-19.
Thank you. So on that question of procurement then and sufficiency of equipment being available, is that something that you think should be handled differently, could have been handled differently?
So I think again it's another reflection on the pandemic, and it was managed later on. It became okay, but then I don't think we had quite that acuity. So if we can see that particular organ support systems are going to be challenged by an infection, so we saw that lungs, the need for ventilators, and then the kidneys as well, that people should learn from this and be able to, if at all possible, just as we needed, PPE, we needed other forms of protection, to understand that there will be this type of treatment could be needed, and to deploy some of the learnings we had here, which was sharing across the country, which was training for more staff, and there were also sort of introduced additional techniques whereby people could be given. I talked about the dialysis in the tummy, the peritoneal dialysis, so there's a technique you can do that urgently as well as through the needles in the arm. So that technique was also identified to give continuous renal replacement therapy for people. And so there's there's about equipment, there's about training, and there's about smart purchasing and distribution approaches as well. And all of those things, I think, are something to reflect on. And in terms of innovation as well, because those products aren't made in the United Kingdom, and that's why that was one of the particular things they had to be gotten from other countries quite often.
Thank you. And finally, on this segment, what was the decision taken during the pandemic with regards to kidney transplants? What did you notice in terms of the rate or frequency of which they were being undertaken during the pandemic?
Yes, so a kidney transplant is a gold standard treatment for somebody with kidney failure. If they are suitable and well enough to be able to receive a transplant, you can receive a transplant from a living donor. I mentioned earlier that was how I got my transplant from my husband, and that's about 1/3 of all the transplants. The remaining 2/3 will be from deceased donors, and people are, of course, incredibly grateful for that gift of life. When the pandemic started, transplant doctors, kidney doctors, were quite concerned because they didn't know what effect having a transplant would have on somebody with kidney failure in terms of their additional COVID infections or COVID risk, because you may, as I explained earlier, if you were taking some some drugs to suppress your new kidney rejecting, that could make you, like a baby, sort of extra vulnerable to COVID. But that of course has to be balanced about the risks you have of having to go to dialysis all the time, and perhaps being next to other people who also have COVID and that level of infection. So plus our staff, many of the kidney transplant type staff would be ICU staff who had to be deployed into saving people with COVID in the intensive care units. So especially over that first year, a number of the transplant units closed or really slowed down the numbers of transplants they were able to make, only giving them to people who were at the very, very highest risk. So some heart transplants went along, or people who were perhaps at very, very low risk, some of the perhaps younger people who could be eligible but were considered just to have a less high risk if they received a transplant. The overall effect of that meant that the numbers of people waiting for transplants, we still haven't recovered. We're at the highest the highest number of people on the transplant waiting list than we've been for, I think it's 9 years now. So the two transplanting units in Scotland, in Glasgow and Edinburgh, actually did really well. They continued doing some level of transplantation, whereas other units, particularly in England, had to virtually close. But nevertheless, overall, with living donation, because you have two people involved with that, and in terms of the donor and recipient, and deceased donation because of the way in which staff were deployed as well, and the unknown risk of somebody newly transplanted getting COVID, or indeed if the donor themselves had COVID and deceased, meant that the transplant system slowed right down and people missed out as a consequence of that, unfortunately.
And what therefore is your view on the decision that was taken, and this is something you cover in paragraphs 101 and 102 of your statement, where you talk about the Scottish Government's response, took a decision as to whether to pause transplantation except in the most urgent of cases.
Yeah.
You then go on to say in paragraph 102, whereas it was sometimes considered, and you will agree or not agree with this, that people who were on dialysis could wait, and therefore they would just be waiting on a transplant, this was for some a real risk to life. Can I just understand what your view is then on the decision that was taken, whether you think it was right, wrong, somewhere in between? What's your view?
I think it's really hard now to look back, because at the time we didn't know. We didn't know enough to balance out those risks. And what we now know is that there is a level of, there are ways in which transplants can be done quite safely, and that's what happened in the later years of the biggest part of the pandemic. But at that time, I think some policymakers considered that, well, people were being treated, they had dialysis, they could carry on in that way. But we heard from many patients, many people waiting and hoping for a transplant, that I think there were two things. One, they did understand that the staff were absolutely taken up, and they understood perhaps why a transplant wouldn't be right for them at that very moment, but they also didn't know what their situation was. So were they still listed? Had they been temporarily suspended from the waiting list because of the overall COVID risk? And a lot of people came to us with great anxiety about all of that. So I suppose, if you ask me now, I suppose we would say that more people could have been transplanted during that period. But in the middle of that, I think many people understood, felt that they were so supportive of the NHS staff and what was happening in the transplant units that they did understand that for a period of time. But the communication with them about their risk and about whether a transplant would have been right for them and whether they should be suspended from the list, that could have been improved. So it's back to that, and I think people would have, because it came back quite slowly and we had a bit of variation in different parts of the country, I'm still not quite clear what the best thing was to have done with that, but I do think communication could have been better, and I dare say that some people, their opportunity to have a transplant was certainly delayed for a period of time, and that's never good, but perhaps we had no choice.
Just to remind you, you're getting time critical, Mr. Stephen.
Yes.
Sorry.
Yeah. And finally on this, Ms Loud, you also talk in your statement about the monitoring or checkups of those who'd already received kidney transplants. And I think you yourself say that you didn't see a kidney specialist for 2 years. Again, is that something that your organisation was informed of is happening regularly? What was the position during the pandemic as to those having their health checked, as it were?
So, through our surveys, we had, I think, 11 question time webinars, we called them, through all those different routes. We had lots and lots of communication with people like myself who had transplants, and the ability to get a checkup was really variable throughout the country. So some people were able to get their checkups locally, their blood tests locally. Some people weren't. I wasn't able to get one locally because there was no link between the IT system in my local part of the country and the part of the country where the transplant hospital is. And so there was a bit of that was an issue in terms of how IT works, and I think some people missed out for that reason. We did introduce, the NHS introduced much more virtual monitoring, virtual meetings and appointments for with doctors and patients, and that was a welcome way to approach it, but that doesn't necessarily replace a blood test. So I think, again, providing joined up IT system, being able to get local blood tests so that monitoring can continue even during a period like this, so you don't actually have to go to a hospital where there may be a major infection and wait there for a blood test. That could be much, much better.
Thank you. Can I move on to shielding, which is something you've mentioned briefly already, but I'd like to just touch on it in a little bit more detail. When those deemed most clinically vulnerable were first asked to shield from March 2020, were those on kidney dialysis included within that list?
No, they weren't. So people with transplants were asked to shield, but initially, although there had been a press conference when, and I can't remember whether it was Chris Whitty or someone else said that the list of people who would be asked to shield, and I think it was around those 2 days when the initial lockdowns were announced in about March 20th, something was 2020. They mentioned people on dialysis, and then when the shielding list came out, people on dialysis were not on that list. Now in Scotland, there was a difference, and initially the shielding list showed people on dialysis. However, within 24 hours, people on dialysis had disappeared from the list. I had quite a lot of communication with medical staff in Scotland about whether they knew what was going on and why dialysis had been taken off the list, and no one was ever able to give me a straight answer. So I do think that is one of the learnings from the pandemic, is that people on dialysis, because I've already explained that some people on dialysis did die, were very vulnerable, just as people with transplants were, of course, but people on dialysis were very vulnerable to COVID infections, and they did need to have that level of protection from shielding. And it wasn't indeed till October 2020, so that's from March to October 2020, that people were not specifically named on the shielding list, as it didn't actually say, this list includes people on dialysis.
And you stated that those people on dialysis were vulnerable. Do you consider that something that should have been understood and known at the time when shielding was introduced, or not?
Yes, I absolutely do that. I do consider that. In fact, that excerpt I read from you from the UK Renal Registry report, reporting for those first 3 weeks of the pandemic about numbers of people getting COVID, and also, unfortunately, sadly, levels of people passing away with it as well, reflected that. And we did work with our medical colleagues to find ways round how people could be listed as shielding, and in a number of cases, it was the doctors or the specialists who wrote to their patients to say to them that you should shield, you are able to shield. But because, if it doesn't say your condition on a public list that you see, then people can lose out, and people did lose out because they would have not been able to receive the food boxes, for example, for which they would have been eligible had they been on the shielding list. And I know that if you go to hospital 3 times a week, you can't shield entirely, but you could. There are areas which people could have been provided additional protection for at that time, which were employment protection, as I say, access to food, to shielding boxes, or just supermarket priority deliveries, for example. And those would have been things that people could have had and they didn't have at the beginning. And it was only a little later in October when guidance was officially changed. But there were nevertheless many doctors, specialists, who did write to their patients and explain to them that they could be considered as shielding and should be done. That should happen to them.
And did your organisation make specific efforts to contact the Scottish Government when those in kidney dialysis were not on the shielding list to begin with? We did, yes. We made a number of contacts with the Scottish Government and via both MSPs and directly with the Health Minister, and we received some guidance back about people being on something, I think it was called Level 7. So there were 6, well, I can't remember whether it was called Level 7 or something else, but there were six kind of categories for which you could shield, and Level 7 was for people who felt that they should be on the shielding list but weren't named on the shielding list. But that meant you had to know that you could qualify onto as a level 7 and through that route. And of course, not everybody would have been able to read that. Not everybody would have seen that information. And unless they'd received a letter directly from their specialist, which some people would have done, but some people didn't, or unless you were very directly connected with a charity like ours, putting up all the differences in all these different levels and the different ways in which you could qualify as shielding, then you would have you could well have missed out. And I think that is something we'd really like people to learn from, that there is really a vulnerability in people on dialysis as well as people with transplants to infections like this, because that's what the data shows us. Thank you. And I was struck by the use of your language. You talked about ways round being found if you weren't on the shielding list to begin with, for example, contacting a GP. What does that suggest to you, if anything, about the consistency of how people ended up on the shielding list?
Well, that unless you were in a specifically named category, for those other people, you could miss out. And so there was a lack of consistency there. And also what we found was that if the letters come from GPs, not every single GP would have the full set of information about their patients and their status. And that was probably part of the reason for the inconsistency we found, in fact, throughout the country, with people who could have been shielding or perhaps should have been shielding but weren't given the advice and support to do so until it became explicit in October 2020, following a lot of campaigning and some new information that came from something called the Q risk analysis from Oxford.
And you mentioned earlier in your evidence about communication more generally when we were talking about the guidance available across the board, but if I can ask you specifically in relation to shielding, what would be your assessment of the quality of the communication that was given as regards shielding from the Scottish Government?
I would say that the communication that came from the Scottish Government, when people received it, was good. It was clear, and on occasion they listened to some of the things that charities like ours were saying, and we got some good feedback about that information. But not everybody got that information, and that would be something that, as I said, that there is some regret on as well. But I would also say that not everybody received, as I say, not everybody received that information in good time, and there could have been improvements in the way in which it was publicly delivered. On occasion, we were told that there was some new guidance coming out, which we very much appreciated. So the Scottish Government would write to us and say, this is confidential, but the First Minister's going to say it, but we may only have had a couple of hours or an evening to learn about it. So in that instance, there was no way for us to feed into it. It was just for us to accept it and place it onto our website and share it with those that we were supporting.
And when you say there that people didn't receive the information, can I ask why you think that was?
I think because sometimes people weren't on the right lists, and so sometimes it would be a specialist who would write to that person because they knew that person, say, was on dialysis, but it might be that somebody had very late-stage kidney disease, and perhaps it was thought that the GP should be writing that letter instead, and maybe the GP didn't have the most up-to-date information. I think there's been a lot of discussion about lists and people having different lists and not necessarily being able to use those lists to write to get all the different people, and we worked with some MSPs and others to ask questions, but it did seem that a number of people, and we heard this through our Scottish advocacy colleagues, that people who would have been expected to be written to were not being written to, or being written to much later than others, and we don't know what the difference in that was, but it was probably to do with admin.
So when you say in paragraphs 63 and 64 of your statement, we tried to improve shielding lists and the Scottish Government did eventually make those improvements, is that the improvements you're talking about, improvements to these lists? Is that what you mean?
That is correct. That is what we were trying to do, and that is what we were writing letters to Health Minister for, sending out briefings on, and hearing back from patients with their huge concerns. And I do remember one of my colleagues, some of our own colleagues, were very, very upset, hearing from people who themselves were so upset because not being able to get hold of food, really, really worried about their jobs. These were the impacts of people not receiving the information they needed at the time in which they needed, despite the massive efforts that we all made to either change policy, and once the policy had changed, to get to see that through, so people were getting the information and the vital support they needed.
Thank you. And I think you've given a few suggestions already, but is there anything else you would like to say on lessons learned specifically as regards shielding, things that you'd like the inquiry to consider?
I think it would be really helpful for the inquiry to consider why people on dialysis were not initially put onto the shielding list, to consider sharing information, and we have very much appreciated the information that was shared with us from Scottish Government and the listening ear, but actually perhaps to work with us a little bit more openly so that we can do more sharing of that and further information, to make that as rich and as easy to understand as possible. And I suppose overall for people, policymakers, to understand that there was always going to be, unfortunately, an additional vulnerability for people with kidney disease to an infection, pandemic infection such as COVID-19. But at the same time, obviously, I do wish to give some thanks to our medical staff and all the systems that did their best. But that doesn't mean we don't think it could have been improved in some of the ways I've just suggested.
Thank you. Ms Loud, I don't have any further questions for you. Just to reiterate my thanks for your evidence, and the inquiry will obviously take into account everything that's in your witness statement, even if we didn't cover it today in oral evidence. Was there anything else, finally, you would wish to add that would be helpful for the inquiry to hear before we conclude your evidence?
I think that there's a couple of things, if I may. Is it okay for a couple of minutes? I know you've talked about time. Is that okay?
I actually called critical time rather too early. I apologise for that.
Oh, okay. Thank you. I just wanted to be clear on that. So, okay. So just a few things. We talked about the reduction in dialysis sessions. There was something else which was about eating and drinking bans during dialysis, because units were so concerned about people who, if you imagine, they're sitting on a machine for several hours next to somebody else sitting on the machine for several hours with needles going into their arms, so they can't move very much. So some units, but I can't give you exactly which units for obvious reasons, but some units, we heard reports back that people were not able to, were banned from eating and drinking during dialysis. For some people who perhaps lived in difficult social circumstances, sometimes that will be their only opportunity to eat, or they might have been given a sandwich on their dialysis session. And some patients are quite at risk of malnutrition. So not being able to eat or drink during dialysis was something that we heard quite a bit about. And in the end, some units did adapt their processes to advise that people could take their mask off, have something to eat and drink, and then put their mask back on again for their own comfort and support as well. So that would be one thing to think on. The next thing was about challenges of transport to and from dialysis, 6 journeys a week. We actually heard quite a lot from patients during that time that they thought their transport experience had improved, and that was because of the risk of infection. Eventually, smaller transport vehicles were used, which meant that rather than having to wait while a little van would go around and perhaps collect 4 or 5 people to go onto the dialysis and go to the hospital, collect them from their homes, take them to the hospital, that because of transport risk, over time, people would be able to receive just a lift just from one person in the taxi or the transport as well. So it was a curious reflection on something that people often mark quite badly in the annual patient reported experience measure. So the individual transport, while perhaps not possible at all times, was much more timely, and that helped their own experience of getting there and back. So that was something interesting to think about. That people on dialysis themselves told us through our various surveys that they needed more care and more communication from their teams, and they needed additional mental health support. And we haven't talked about mental health support very much at all. But I think it's probably quite reasonable to expect that if you are asked to shield, if you know there's an infection that can really affect you, especially in the times before vaccination, that your mental health might be affected. And I have to say the Scottish Government did do a couple of surveys to look at the impact from that, and in its messaging to try to offer people ways in which they could address that. But I think facing that up front would have been something for the inquiry to think about as well, and the longer term impacts of that. And I suppose finally on that point, which is, and it's probably tell me if it's out of scope for today, I have talked a little bit about, in my evidence, about vaccinations and people being able to access their vaccinations in a timely way. And we did get some support from some MSPs, because we needed to, once the vaccinations became available at the end of 2020, there was a further push for people on dialysis to be able to receive the COVID vaccines. And at first, people with transplants were prioritised, but people on dialysis also needed that prioritisation. And I think that would be a further lesson to learn, is that because people were exposed to others, they did need to have that prioritisation, which eventually took a bit of a push to receive the COVID-19 vaccinations. And I said finally, but there is a further point than that, that despite the vaccinations that people received, there remained a group of people, even now after receiving many vaccines for COVID, who are not able to produce the same antibodies as everybody else. And for them, there does remain, thankfully, a range of treatments that they can receive. And I think that message perhaps isn't as clear as it could be, although I checked the Scottish Government website, it's still on there that there are treatments available for people who remain additionally vulnerable to COVID. And while we encourage people to take their vaccines as they are offered and their boosters as they're offered, that there are these additional treatments available for them as well, and they should be aware that they're still there. And again, messaging about all of that just needs to be as clear as possible, because for some people, you know, the impact on their mental health, having had to shield, some people are still shielding because they're still concerned, but there remains, even though this is part of perhaps sort of learning to live with COVID, but there does remain a risk to them from COVID, and still it's prudent to know what the advice is and that there is treatment. There are some treatments available to support people who contract it. So sorry, that was rather long, apologies, but there's still some lessons to be learned, and some of that we've described in our evidence. And I hope that what I've said today is able to kind of contribute to what was a very emotional time for us. It's a very challenging time for us, and that we did and continue to do promote the best possible risk-based communications and prioritisation for people who have a level of vulnerability to something like COVID-19, and that we can learn those lessons for future pandemics, and minimise the risks, minimise the mental health impacts, and be more forward in prioritising people with kidney disease.
Thank you very much for those additional points. Thank you.
Thank you indeed, Mrs. Loud. Very good. About 15 minutes? Very good. Thank you. Right, now, good afternoon again, Mr. Gill.
My Lord, good afternoon. Next witness and final witness today is Dr. Claire Taylor.
Good afternoon, Dr. Taylor.
Good afternoon.
Yes, when you're ready, Mr.
Thank you,
Gill.
my Lord. Dr. Taylor, your full name is Claire Taylor, is it? Your personal details are known to the inquiry, your age and your contact details. And you've provided the inquiry with a statement. The reference to that statement is SCIWT 0562 and then 501. And just for further reference, there is a document that is footnoted in Dr. Taylor's statement, and that is an excerpt of an article from the Lancet, a paper from the Lancet from October 2023, and its reference is the same start, but it's 502. And if we have time, we may look at that probably fairly briefly with Dr. Taylor in her evidence. Doctor, you provided a statement for the inquiry, and we're very grateful to you for that. I think you are content that the statement, together with your evidence today, is your evidence for the inquiry to consider, and that you're content that your evidence is recorded and published.
Yeah.
You're a medical practitioner, and your academic and professional qualifications are set out in that section of your statement headed background, and we can read those. You have an honours degree in neuroscience from Edinburgh University and a degree in medicine from Dundee University. You have a background as a general practitioner, and I think you've practiced in various locations in Scotland over the years. And when the pandemic began, exactly 4 years ago, you were working as a GP, both for a local health board and for individual practices. All right. Now, you're here, Doctor, to provide the inquiry with your experience of treating patients with long COVID. So I'd like to understand how you came to be involved with the treatment of long COVID. But before I do that, can I just ask you to go to the end of your statement and to paragraph 146. And so that we have a little flavour of what you're going to say, you say that no other doctor is doing what I've been doing for several years now, and that's in the context of long COVID.
Yeah.
And you say, I must have seen the most patients in Scotland with long COVID.
Yeah.
You've said you've never been consulted on any decision making, and I think you found the exercise of providing this statement for the inquiry quite informative, because you've said that you've been asked more questions in this interview than I've ever been asked before.
Yeah.
So, with that perspective, the information that you're giving to this inquiry is, can we say, probably the most comprehensive account of treating patients with long COVID that you have given.
Yeah.
In public.
Yeah.
Thank you. Now, just in relation to your background and how it assists in your treatment of long COVID, at paragraph 12 of your statement, you indicate that in October 2020, so we're into the pandemic, you applied for a job working for the ME Trust. And can you explain why you did that?
So I had done various specialties throughout training and as a doctor, and I was particularly interested in people who had symptoms of what appeared to be a rheumatological disease, inflammatory disease, but bloods were normal and but they were very unwell. And ME is one of those diseases. So when this job came up in 2020, I was already seeing people who'd had COVID who had not recovered, and thought it would be a good fit for me, and to see if I could help these patients.
And the work that you were doing for the ME Trust, I think you tell us in paragraph 13, was for a year.
Yep.
And you were working 1 day a week online.
Yep.
And looking at the overall condition of patients.
Yeah. So even though it was online, there's still a lot that could be done. And actually, a lot of these patients couldn't access NHS care. This was through a charity, obviously, but they couldn't access NHS care because they're housebound, a lot of them. And when you're housebound, if you're then sent an appointment for, I don't know, a cardiology appointment at the hospital, that could be a major difficulties in accessing that care. So I could take a full history over what medications people were on, and I could get them to do some simple tests at home and get the results back, and from that make a plan to try and improve their condition. So quite a lot could be done even though it was online. And there was a long waiting list. This had existed before I obviously did that job. Somebody else did that job. But it originally had been a hospital, and over the years it had been downgraded into a service where people could consult online.
Right, all sorted? Good, thank you. On you go, Mr. Gale.
Doctor, we were talking about your involvement with the ME Trust. When you applied for that job and thereafter, when you had it, were you also seeing patients in your capacity as a GP who had symptoms of post-viral infection from COVID?
Yes, so I had a mix of patients. I had patients who'd maybe had ME for a long time, and then I had patients who'd had COVID who weren't getting better as they'd expected, and had looked to see what was available and saw me either with the ME Trust or in my own practices. They would seek me out. But yes, lots of patients in 2020 and into 2021-22.
You tell us in paragraph 15 that you noticed that ME patients and those who had COVID had quite similar autonomic and allergic problems as part of what was wrong with them. Can you just explain what autonomic means?
Autonomic is a word that is similar to automatic. So your body does something that you don't have to control, like your heart beating, or you're not consciously aware of that. And it can be connected to your brain, and signals between those are autonomic.
And what were the similarities?
There was a high prevalence of a condition called postural orthostatic tachycardia syndrome.
That's POTS, I think.
POTS, yeah. And that was very obvious to me very early on that these patients shared POTS in common. And also that they were more likely to be allergic to things randomly. They could be allergic to things. Their immune systems were overreacting to things they wouldn't usually. And they also had post-exertional malaise, a lot of them. So in common, there was these particular features.
Right. Now, you had also, I think we can see this in your background, you have some experience of cardiology and also rheumatology. Is that right?
Yeah.
And were you able to bring those experiences to bear in relation to these patients?
Yeah, so I supervised what's called tilt testing in Dumfries and Galloway. It would be about 10 years ago now.
Right. Can I just pause you there? Can you tell us what tilt testing is?
So tilt testing, POTS is when the blood in your body should, when you stand up, it should go up to your brain, and that should happen automatically. And if it doesn't, the blood is not getting to your brain, and your heart rate speeds up. And one way of testing it is with a tilt test, where you attach somebody to a bed and you essentially tilt it up and you watch what happens to the heart rate. So it's fairly niche to be supervising those tests, and it just happened in one of my rotations. I was supervising, so I knew about POTS, and I would say that it's not as well known about in medicine as it should be or could be. I already knew about this condition and recognised it very quickly.
And in relation to those people who are presenting symptoms post COVID infection, was POTS an issue?
A massive issue.
I think you've given an indication of, I think it's 80% of your patients. You identified that as an issue with them.
Yeah, and the prevalence in research papers would be between 40 and 80%, depending on what group of patients you're looking at post-COVID. But certainly the patients that I've seen, most of them have POTS that hasn't already been diagnosed. So they've often had it since they've had COVID, and it's not been diagnosed in these patients.
Right. You tell us also at paragraph 19 that you attended your local health board meetings on what to do about long COVID and gave your own perspective. Now, just before I ask you some questions about that, the term long COVID, when did that start to assume prevalence in medical parlance, if I can put it that way?
So the term long COVID was coined by patients mid-2020.
Right.
And there are other terms used in medicine. Post-acute COVID syndrome is one of them. But long COVID has stuck, as it were, as I would say.
It's a simple term.
Yeah, it's a simple term that I think everybody understands.
Yeah.
Yeah.
Good. Okay. So you were providing your own perspective at health board meetings, and you tell us that you were cautioning that physiotherapists and occupational therapists were burning out. Can you explain why that was happening?
So the patients were referred, and every health board is different. The one I was in, the patients were referred directly in from their general practitioners. So they might have had some blood tests. They might have had a chest x-ray. What they hadn't had was a full physical history examination and investigations by somebody who knew more about long COVID than they did. And the physiotherapists were trying to work with people who had POTS, who every time they stood up their heart rates doubled, and they couldn't do the rehab they were being asked to do. And that's very difficult for those physiotherapists because they could recognise the problem, but there was nobody there for them to ask for treatment or advice. So they were essentially trying to rehabilitate people with the rehabilitation model who needed more medical input first.
Okay. All right. And you tell us that you were met with the comment, which I think is probably apocryphal, but you've given it. People just need to exercise.
Very common.
Who are you getting that response from?
So from other doctors, that these patients weren't trying hard enough, that they just needed to get back to what they were doing and build it up, and they would be fine after that, and they didn't need anything else.
At that time, and in your view, was exercise beneficial to patients who were presenting with these symptoms?
No, because we know from ME and the change in the NICE guidance in 2021 that exercise was taken out of the NICE guidance for these patients, graded exercise, because they found when they re-examined the studies that it wasn't beneficial and could be harmful. And given many of the long COVID patients, about 50% of those meet the ME criteria, that they were unlikely to not only not benefit, but for it to be harmful without it being properly supervised and individualised plans for people. So it may not be the case for every single patient, but certainly for at least half of them could be potentially harmful.
So as a piece of generalised advice to effectively get out and exercise was not particularly helpful?
No.
And I think you say that this has since been confirmed in studies. You haven't given the details, but you've obviously seen these studies.
I have. I've seen the most recent one is that in about 1/3 of patients that they studied, there was muscle necrosis, which meant that the muscles were breaking down and dying after exercise. And there was about 2 weeks for those muscles to regenerate.
Okay. You do tell us, and don't worry about naming this individual, in the next paragraph, because it's an individual who is well known. You were at an award ceremony for long COVID kids, and you say that you're one of their champions.
Yes.
And we'll come to long COVID and children at a later stage in your evidence. But at that ceremony, you spoke to the then Health Secretary, Hamza Yusuf, and who is now First Minister, obviously, and you gave him certain advice and information. Can you tell me what you told him?
So we had a chance before the ceremony to mix, and I said that the model that we had for long COVID patients wasn't working and wasn't going to work, which was the model of sending people to physiotherapy and occupational therapy without a medical person involved in that. And he listened and said we should have a chat sometime properly about it.
And did that subsequently happen?
So I did have a chat with him, with Helen Goss of Long COVID Kids, and she and I both put the same point across in the meeting in 2023. But it was a proper meeting to talk about the model of healthcare and also about the dangers of COVID and what it can do to the blood vessel system. And we also discussed that and my concerns about the effect on the population of repeated COVID infections.
Now, with this basis of experience, you set up your own long COVID clinic, and we can read about that. First of all, why did you decide to do that?
So having attended health board meetings and tried to put across that I felt having a doctor that knew about conditions like this and having worked with the ME Trust, felt I had that experience to see if that worked better. When the money was awarded in 2022 for health boards, there just wasn't the money for the area to employ a doctor to do that. And at that point I realised I'm either going to just not do any work at all on this at all, or stick to my own practice where I might have, half a dozen long COVID patients, and that's it. And the only other way to do it would be to set my own clinic up and see what happened. So I just sort of did it and thought I'll see what happens, and very quickly booked up for 6 months fully with patients desperate to be seen.
How is your identity made known as somebody who is providing this service?
I think it was mainly patients telling other patients, I've seen this doctor and she can offer more than. I've never advertised my services. It's just sort of known that I have my long COVID clinic. I also see ME patients there, POTS patients, and I have this clinic, and patients find me.
Right. The clinic is private, is that right?
Yeah.
How does that sit with your general philosophy towards the provision of healthcare?
So I grew up in a household where we probably couldn't have afforded to go to private healthcare, and I wrestled with it a lot because I really believe in the NHS and free healthcare for all, but it was either nothing or offering something. So in the end I thought, well, maybe I can do this, and maybe the NHS could learn from this, and maybe I could help implement it, but doing nothing to me was worse than doing something. But no, it doesn't sit well, but currently still is the only way I can provide those services.
Okay. You personally have had COVID several times.
Yeah.
How many?
6.
It's confusing my breath, and that's an awful lot.
Yeah.
Or it seems to my ignorant.
I think occupational hazard.
Oh, is that what it is?
Yeah, it's part of it. I think being a doctor, and we were around a lot of COVID.
Yeah.
I'll come to symptoms of COVID in a little with you, and we've heard, and I know you are aware, we heard from Mrs. Ormrod this morning about symptoms. So we will look at that in due course. But can I just ask you, from your perspective, what effect treating patients with long COVID has had on you? And I'm not talking about being repeatedly infected with COVID, yes. Just upon your ability to do it.
So the effect on the patients?
No, on you.
Oh, on me. So I do all of this on my own, and I don't have much administration support. I have very desperate patients who are about to lose their jobs, who might have to retire early, who need support. So I'm supporting lots and lots of people all at once. So yeah, I've taken on a lot. I would say as a person.
You do touch on this at paragraph 129 of your statement. And this is in the context of mental health impacts. And you do talk about the need to protect your own mental health.
Yeah, so
how do you do that?
I'm very lucky in that because of social media, I've managed to make connections with other doctors who are interested and want to learn about long COVID and to help people. And so I have lots of people that I can speak to and that I hadn't met before I started working with long COVID. And so there's always somebody at the end of the phone, especially if you've had a very difficult case and you work on your own, you might have had a very, an upsetting consultation. There's always somebody that I could speak to.
Well, I think that's possibly the point I'm wanting to get from you, Doctor, is that some, as you put it, some of the horror stories that you hear are clearly very distressing, and I'm just interested at the how you cope with those.
I think I cope with it because I'm a doctor and I need to help them, and that's my job. So as a professional, that's my job, to help these people in their time of need.
How many patients do you see a week?
So it's around 16 per week, and they need a lot. I need an hour with each person to see them.
And what does a consultation with you involve?
So it can either be in person or by video link, and I do a full history of, before somebody had COVID, what their life was like, the symptoms of COVID, what they've had since, any investigations, examining them, checking if they've got POTS, and then going through a treatment plan. So it usually takes about an hour, and then they get a letter back to their doctor or their GP with what we've talked about, and a plan, and sometimes referral on to other people.
Right. And so you don't refer back, you report back to the patient's GP.
Yeah.
Will the patient have come to you with a diagnosis of long COVID, or are you the provider of that diagnosis?
Most of the time they have a diagnosis from their doctor, and they've been on waiting lists for NHS services and they're still waiting, or they've decided they want to see me because they've heard about me. But generally they've got diagnosis. Some people, it turns out to be another diagnosis, so that's part of the job as well, is making sure they've definitely got long COVID. But I would say most people have the diagnosis, or are looking for confirmation of that diagnosis sometimes too.
And are you in a position, having made a diagnosis, and I suppose depending upon the nature of that diagnosis, offer treatment to that patient?
Yes, so there is, although none of the guidances that we have treatment in them, there are treatments for some of the problems that the patients have, like POTS, like they're hyperimmune, so their immune system being overactive. There are treatments from other conditions that we can draw from. There's treatment for fatigue and MS, for example. We can draw from that. And so there are treatments that we can use. They just aren't in the national guidelines yet because they were made a couple of years ago and they've never been updated.
What about a referral to specialists? Do you do that?
So you can refer from private into the NHS. That's in the NHS Constitution. And so it would be depending. Most of my patients don't have much money. So they're not the usual people that would be accessing private care, and they don't have the money for lots of referrals and tests. They don't have private insurance. So if they, for example, are having chest pain, then I would refer to a cardiologist and say, could you please investigate this chest pain in particular, make sure it's not this, or have they got myocarditis, for example. Sometimes the GP will do it, but I try and do as many as I can. Some specialists haven't accepted those referrals because they are from private provider and not NHS.
Right. One of the things we heard from Mrs. Ormerod this morning was one of the difficulties in a GP referring on a patient with, as she put it, a myriad of various symptoms, is to identify the specialist to whom that referral should be made. And she used the word, this does not allow for a holistic approach. Is that something that you recognise? Yes.
So, like I said, if they've got chest pain, cardiology, if they're short of breath, respiratory, neurological symptoms, neurology, and these professionals don't tend to communicate with each other. And what you get is patients that go to different clinics after a different length of time with it's not this, it's not that. That's usually the outcome, is it's not this, it's not that. Not everybody gets all of the investigations that I think they should have. So with relation to chest pain, for example, they might just get a phone call and that's their appointment and not have any investigations done. So they come back often no further forward than they were at the start of that. So there isn't one person or a group of people working together looking at that one person and what might be causing their symptoms. And some of the things that can cause chest pain in long COVID can be serious. So they can be blood clots, they can be inflammation of the heart. So it's not, you're looking for serious outcomes of this disease, and without people communicating together, the cardiologist might say, well, it's not myocarditis, but then you might have the question, well, is it a blood clot? Back to the different specialty.
Okay. Sorry, there was one point, and it's my fault. I should have asked you about this earlier. Paragraph 11, don't need to look at it, but you do mention there that you sit on an advisory group for long COVID run by the World Health Network.
Yeah.
Can you just tell us a little bit about that?
So the World Health Network has a group of doctors like myself who are interested in COVID and long COVID, and we meet every 2 weeks to discuss research. We are currently writing a paper on treatment, and we've given public talks on it for the public if they're interested, and we've done a variety of public things for people to learn more if they want to.
I think you specifically mentioned that it's an apolitical organisation.
Yep.
Is there any significance in saying that?
I think they just present the science as the science is. So that is what I mean by that. Is there's no
overlay.
No, that's what we present and what they present is what the science is telling us, and that's what's presented to anyone that's interested in learning more about it.
Okay. Right, can we turn to some of the specifics of long COVID? Now, Mrs. Ormerod this morning in her statement provided us with the World Health Organization definition of long COVID. You'll be aware of that. Is that the accepted definition of long COVID now?
It is. The only differences you sometimes get with definitions is the length of time.
Right. Yes, there are months and
yeah. So the ONS study that was monitoring long COVID was 4 weeks, for example, ongoing symptoms post 4 weeks. Then we've got 3 months for the WHO. So I think the accepted is usually 3 months, I would say, if somebody's not better in that time, that you can call it long COVID, because a proportion of people will recover in the first few months.
Right. One thing I'd like your thoughts on, and it's something that we've addressed with a number of witnesses, but I'd like your thoughts on it, and that's the skepticism that surrounded long COVID, particularly in the early days of the pandemic, and which may still exist. As a medical practitioner with a degree of expertise in treating long COVID, do you have any comment to make on that?
I think this is comes from what's happened with ME/CFS over the years of the history of it being psychosomatic, e.g. it's in somebody's head. And I think it's a follower from that, because it's similar. It's post-viral. A lot of ME is post-viral. And for many, many years, patients have been treated like they either haven't done anything to help themselves, or they're not really that ill, or it couldn't possibly be that bad, or you might have people saying they're the type of person that would get that sort of disease. So a lot of stigma around post-viral illness, and it would have been highly expected from the SARS-1 incidents that lots of patients wouldn't recover.
You mentioned stigma on at least one occasion in your statement. If now can't actually find where it is, so apologies, but you do mention it.
Yeah.
Is that stigma a difficulty, first of all, for patients themselves?
Absolutely. I think it causes them problems with work. It causes them problems with accessing healthcare, with maybe friends and family. And if you look at the way long COVID is written about in the media, depending on who's writing it, you can see that they are not taking it seriously. These patients are extremely unwell and can't do the things that they used to do. So definitely for the patients, I would say having a diagnosis of long COVID can be very difficult for them.
Is the stigma still the same now as it was, say, 2 years ago?
I think it's still the same, yeah.
We heard from Mrs. Ormerod this morning, and she referred to the stigma in particular in relation to children.
Yeah.
Now, I know you don't treat children, you don't treat anyone under the age of 16, yeah. But from your own perspective and your own knowledge, is the stigma attached to children with long COVID particularly damaging?
Absolutely. I might not treat them until they're 16, but I've got their history when I see them at 16 for maybe the last couple of years of their illness, and they've had the same things said to them. Patients will tell me what they've had said to them. I've been told that I need to just get back to doing what I was doing, but they can't get back to what they're doing, which might be school, for example, because they're too unwell. And in that age group, telling these children that they just need to try harder when they've had a virus that has multi-system effects, and then nobody's treated those multi-system effects, I think is particularly damaging for them and their trust in healthcare.
Thank you. Can we look at some of the symptoms, please? And again, we had the benefit of Mrs. Ormerod's evidence this morning. I think you were aware of it. And so she's described some of the symptoms. You describe them at paragraph 44 of your statement, and I'd like to look, please, at the first three of those. The first is extreme fatigue, and it may well be that, I suppose, post-exertional malaise is attached to extreme fatigue. That may be a manifestation of it. But how do you categorize or characterize extreme when you're describing fatigue?
So with ME/CFS, there is a severity scale, but there isn't for long COVID. However, the most extremely fatigued patients I have could maybe tolerate 10 seconds of talking to somebody for a whole day. The most extreme are in darkened rooms. They have to cover their eyes for the light. They can't get out of bed to go to the toilet. That's the level of fatigue people can have. You have a spectrum of people who might be mildly fatigued, and that they are not able to do what they wholly used to do before COVID. But most of my patients would fall into the category of housebound or nearly housebound or bedbound.
We'll come to housebound because you have a section on that. But post-exertional malaise, or PEM, I mean, we've heard some evidence, I think, there's reference to it in Mrs. Ormerod's statement about people feeling so fatigued that after putting a pan on the cooker, they forget about it, or they're unable to go back to switching it off. Is that an instance of post-exertional malaise?
I would say that it's slightly different.
Right.
So post-exertional malaise can develop immediately or in the next 1 to 2 days after activity.
I see.
Whereas that would be their cognitive problem if they're forgetting. But the post-exertional symptoms can last for several days after an activity.
Mm-hmm. And I think in your statement you say that for some people PEM can even be triggered by talking or sitting up.
Yeah, so I would, anybody with long COVID who gets post-exertional malaise, and what tends to happen is they get COVID, they're not getting better, and then they might try and go back to work, for example, and they find that they might manage that day they've done, and then they're in bed for 3 days afterwards, and they don't know why. They've suddenly not been able to manage a day at work, for example. But for others, it can be, for these very severe patients, as simple as sitting up can actually make everybody will get a different experience of post-exertional malaise, and some patients tell me it feels like they've been poisoned. Other patients tell me that it's like having the flu, and for others it's just they cannot do anything. The energy systems of their body isn't working properly, down to the cellular level. And that's what it has in common with ME, is that these patients, in most of the ME diagnostic criteria, is post-exertional malaise as having to have that to have ME. And that's why about 50% of long COVID patients meet the criteria for ME, is because they have this post-exertional malaise. But malaise is a funny word to describe it, given how unwell people can feel, and it isn't tiredness. It is, I think what I gather from it is like their entire body is dysfunctioning, and if you got it today, you might take yourself off to hospital type of level. But they know now what they've got wrong with them, and in the early days they might have went to A&E saying, I don't know what's happened to me, my heart rate's 160 beats per minute, why is my heart doing this? And then they've learned over time that this is part of their payback for maybe doing something the day before.
I think you do mention in your statement that one of the concerns you have is about the nomenclature of fatigue. Somebody describing what somebody has who has long COVID as having fatigue, almost to the extent that that expression tends to diminish its significance.
Yeah, it's very difficult, the word fatigue, because it may be taken to mean being tired, but it isn't the same tiredness that people get because they've had a busy day. It's this person might wake up as if they haven't been to sleep. And I've heard it described as, as if you've not slept for a week and just woken up. So I think the term fatigue is a difficult one, although there isn't really another one to put in its place. But in this context, it doesn't mean tiredness.
Now, the point you make on that is at paragraph 89 of your statement. And this is where you're dealing with issues that are difficult to treat, but I think you make the point that fatigue is a terrible word for this condition.
Yeah.
And you believe deliberately used to make it seem less serious.
Yeah, we have to look back the history of ME CFS to see why the term kept changing. So it started out as ME, and then it was replaced by chronic fatigue syndrome. And then later on, there's been lots of campaigns over the years. Now, most people would use the term ME/CFS, but chronic fatigue syndrome on its own, there is a history of why that happened and going back into the 1990s, early 2000s, and certainly it appears to be that it was to make it seem like it wasn't a disease that might stop you from being able to work, for example.
Mm-hmm. And I think, again, in this context, you do express the view at paragraph 90 of your statement that you believe most patients have got inflammation at some level in their brain, and the fatigue part, it's not tired, it's an actual inability to meet the set amount of energy required for daily activities as a human. Now, can you explain what you're saying there and how that can be tested?
So there have been tests done on inflammation in the brain, many research papers, and the tests that we use in clinical practice, such as MRI scanning, will not usually show this up. But there was a study done by a private group in America who looked at PET scanning, and they also looked at the blood vessels in the brain. And they found that in the long COVID patients, about a quarter of them, that they had inflammation in multiple areas of the brain that do multiple functions. There have been studies that look at the population, and since COVID, following up these patients who were just in the UK Biobank, it's a biobank of patients, a drop in IQ, there's been grey matter loss. We know that COVID can infect neurons. So I think if we extrapolate what we know from these studies, although we can't currently put that person through a scanner, we know from the research that they do have inflammation in research study.
Right. And I move on to cognitive dysfunction. Now, I'll probably confuse matters by talking about putting a pan on a cooker, and that's more cognitive dysfunction than post-exertional malaise, but or in my case, probably disinclination.
To be fair, if you've got post-exertional malaise, you're more likely to leave the pan on the cooker.
Yeah. The cognitive dysfunction, how does that manifest itself in the patients that you're seeing?
Many of my patients have to bring notes to appointments, write everything down, so they can't actually remember their own medical history. They will tell me about how they are trying to function and they can't find the words they're looking for, so they'll word search, they'll give the wrong words for things, and I would say that even just watching a patient, if you're on video, you might notice at the start of the call they're talking normally, and by the end their face has just dropped and they just can't remember, and they get really frustrated because their brain just isn't firing properly.
Mm-hmm. And is there a treatment for that?
There isn't a treatment for inflammation in the brain as such in long COVID, but there are medications that help to reduce inflammation. And in some patients, simple things like antihistamines have helped with those symptoms.
Mm-hmm. You say in paragraph 92 in relation to cognitive issues, they're very hard to treat. And you make reference to the use of referral to a neuropsychologist. Do detailed assessments, but there are long waiting lists, so most people haven't seen them even after 4 years.
Yeah, and that's to characterise which bits of their function they've lost, because they might have a responsible job where they may need to have that function to do their job, for example. Most people haven't had that done, the other way you can sometimes treat cognitive issues is by treating their POTS, because they're talking about blood going to the brain. Mm-hmm. Blood's not going to your brain, you're not getting enough oxygen to your brain, you're not getting enough nutrients to your brain. That's another way of doing it. But if we have virus still in the brain and we don't know yet what we're dealing with here, how do you treat that? And that we don't have answers to those sort of questions still. And detailing what patients have with a neuropsychologist, at least allows them to, for example, if they need benefits or work adjustments, to say these are the bits that I can't do. And currently all they have is what they can tell people is that they can't order their work, or they can't remember to take the pot off the cooker.
You make an interesting point at paragraph 92, that some people who have cognitive issues may be reluctant to admit to them.
Yeah, I mean, if you think about people's livelihoods, and they may not be able to do their job if they've got cognitive issues, so it ties in with with livelihood and being able to support people supporting their families.
It may be useful to talk about some of the examples of extreme fatigue that you've encountered, and perhaps we can do this under reference to that section of your statement under the heading bedbound patients.
Okay.
Now, you've, I think, already mentioned that there are patients, and you put it by saying they may be of all ages, who cannot tolerate any noise or light, and need a commode for the toilet, need to have tubes for feeding, and the carers come to you to obtain advice, I suppose. So within the cohort of your patients, how many people fall into that sort of category, that they can't tolerate noise or light?
There's many that have light and noise sensitivity, but the ones that are bedbound and not able to tolerate it at all is probably about a quarter of what I see. So it's not the majority, but there is, I probably see more than anyone else of these unfortunate people who can't tolerate it at all. But a lot of long COVID patients will have light and noise sensitivity as part of their illness, but not need to be in a darkened room as such. But these people, I would say probably about a quarter.
You describe it in paragraph 66 as a living hell for a lot of those patients.
Yeah. I don't know how they bear it, especially when they don't have very much support or input. I don't know how their carers bear it, because it's not just a few weeks, it's not just a few months, it's years and years, and they don't know if they're going to get better.
You do give one specific example, which I think perhaps brings out some of the extremity, perhaps, of the difficulty for people with this condition and for their carers in paragraph 69. And you talk about situations where people may have parents in their 70s or 80s and are dealing with adult children who are have long COVID to the extent of being bedbound. And you give the example that those parents may have to hold bags to the bed so that the patient can defecate into the bag. Is that something that is something you've come across?
I have a number of situations of what were independent adults who were working, had their own house, have had to move back with their parents, who are elderly because they've lost their job with long COVID, their conditions got worse, they haven't had any help, and resulted in these sorts of situations where they are too unwell to get up from the bed, and their parents do have to help them go to the toilet in the bed. And I've seen some of these people. I don't often speak to these patients because they're too unwell to speak to me, but their parents, who are doing this often in their 70s, sometimes in their 80s, are completely broken doing that.
Can I ask a question which, at one level, is extremely simplistic? You said earlier on in your evidence that many patients consult you either face-to-face or online. They've been heard about you by word of mouth. They have perhaps, I think in fact you said, they've seen general practitioners who have either sent them to a specialist of an inappropriate speciality or have declined to refer them to a specialist. Now, I can understand that all makes sense. But what you're describing in paragraph 69 is people who've got really very extreme symptoms on any view. And I would have thought, this is the simplistic part of my question, I would have thought people with symptoms as extreme as that would have been seen, not only by GPs, frankly, but would have been referred to, and of course I don't know what the appropriate speciality would be, but an appropriate speciality, or a speciality who would at least willingly look at them.
What often happens is that they get unwell very quickly, and then they can't get to those appointments, and there aren't teams that go out to see them. So it might be that they should see neurology, for example, but how do they get there? How do they get the scans when they can't stand any light and sound? So they can, if they have a gradual decline, they might have seen the specialties, but if they've very quickly declined, there isn't a service that takes them.
I understand that, but if someone had symptoms as extreme as that, particularly I would have thought if they came on suddenly, can either themselves or whoever's with them phone 999, frankly.
So often they will have presented over and over again to A&E with their symptoms, and I've said elsewhere in the statement that they might be told they've got anxiety, that that's the problem. It's not, they can't possibly be this ill, and I think there's a lack of understanding in medicine about how unwell people can be. You could admit somebody to hospital for investigation, and some of these patients have. However, many are concerned that they'll get worse being in a hospital environment because they're going to need a side room. They can't stand the noise. The noise to these people is excruciating. Their brains are so sensitive. So they might be in a position where even if they were offered, you could go to hospital for a week and have a number of tests, that they wouldn't want to go because it would be too painful.
Yeah. Sorry, Mr. Gill.
Thank you, Lily.
Thank you.
I'd like to ask you a little bit about your patients, and just to be clear, please don't mention any names.
Of course.
You wouldn't
No,
in relation to confidentiality, but please don't. Just in relation to your patients, you say at paragraph 48 that your patients don't come to you with one symptom. They're coming with a full package of symptoms. Is that the standard presentation to you?
Yes, so you can define long COVID as persistent symptoms after a few months, but what I see isn't one symptom, it's everything. The fatigue, the post-exertional malaise, the headaches, all of it. It seems to be if you get one of these things, you tend to get more than one thing.
Yeah. And in paragraph 50, you say that the story invariably starts with the situation pre-COVID. And you give a quote, "I was well, doing lots of exercise, working in a job full time, and then I got COVID, and then I didn't get better."
Mostly that's what I hear. I've heard it hundreds of times over, the same opening sort of statement of what's happened to them.
And so far as pre-existing conditions are concerned, I think one of the things we've heard is that certainly in some of the comments that have been made about those people with long COVID is that, oh, well, you must have something wrong with you. And this is why COVID has exacerbated your condition. What do you respond to that?
Certainly in my clinic, that's not what I see. I see people who generally haven't been on any medications or had any health problems. Maybe they might have had a bit of mild asthma or hay fever, but it's certainly not what I see in my practice, is people who have had pre-existing conditions that COVID has made worse. Of course, it is possible to have a pre-existing condition that COVID makes worse, but the actual, as you say, package of long COVID, the multi-system, the people I tend to see were people who were well beforehand and didn't really know that this could happen to them with COVID, because they were told it was mild and they were unlikely to be hospitalised or die. And I'm not sure that most of these people realised that this could happen to them because they were previously well.
Mental health is an issue I'd like to ask about. Paragraph 51, you say very few of your patients have any previous mental health issues or are on any medication when they come to you. And you then develop this at paragraph 127 of your statement, and you say, I genuinely don't think most of them have any deep mental health issues, but I think they have a fear of being told that they are mentally ill as the cause of the illness.
Yeah.
So probably two different perspectives there. One is patients coming to you with long COVID, and they generally, as I understand what you're saying, are not patients who come with previous mental health issues.
Most of the time, no. I always explore how people are coping with their illness, given it's a multi-system illness. And they generally haven't had any previous mental health issues. And often when they've went to their doctor to say they've had COVID, they've not got better, they've got X, Y, and Z symptoms, are told, well, it's anxiety. And they will sometimes be diagnosed with anxiety when they don't have anxiety, they have POTS, for example. As time goes on, I think the illness gets harder to deal with. You know, patients who have been unwell for 4 years, coping with that. And I think that it would be natural in that position to, you know, struggle with motivation or how your moods and how you're feeling when you've got a disease that people don't understand and there's no help for. But generally, what comes to me is people who are working, had lots of activities, social life, and weren't mentally ill. But they do often get then told they have a mental illness instead of long COVID. Eventually, when they don't get better from that, then they get a diagnosis of long COVID.
Right. Just in terms of the gender of your patients, you tell us at paragraph 54, and Mrs. Ormerod has already made this point this morning, that this is a condition that appears to predominantly affect women.
Yeah, so any of these diseases that are what we would say inflammatory, so the immune system overreacting, are more common in women. And we know that when people are pregnant, that they may well get a relief from their symptoms, for example, in conditions such as lupus. So we know that there is an effect of hormones on these types of diseases, and we know that women are more likely to get these types of diseases because of their partly because of their hormones, but also because of their gender, that there is something about women that is more likely to have an autoimmune / inflammatory type disease.
Right. I think you also say that with the skepticism that may exist in relation to long COVID, there may be another element to that, which is misogyny.
Yeah.
Is that something you've come across?
It is. I've had patients tell me things that have been said to them by members of the medical profession, and I do think some of it is misogyny, being told to that it's because they're a female, because of their age, that they've got this imaginary illness, and often the people that do this don't try to hide it from the patient. They're very frank with them, and there's a lot of patients who I will see them and something that's been said to them maybe 4 years ago, it's still stuck with them, that I was told this by this particular, such as, you know, you're this age, you've just put on a bit of weight, you just need to go and do some exercising, and you're, you know, I see a lot of, they'll be told that they see a lot of women like this in this age group. Yeah.
You also indicated, paragraph 57, that in terms of age, most of your patients are between 20 and 50. So that puts them into the working category, I suppose. And clearly, and we heard a good deal from Mrs. Ormrod, and one of the documents that she's provided to the inquiry about the effects that has on the ability to work and the necessity to have employers who are sympathetic towards the condition that somebody has.
Yeah, it just hits right in the working age group.
Yeah. And
employers will be mixed in their response. There's some very good employers who are still employing their their employees, my patients, with reduced hours, for example, but there are other ones who have lost their jobs, and some people are only, you know, a couple of weeks of income to homelessness. You know, not everybody's got savings or a backup. Not everybody's got income protection. Most people probably don't. And they are hanging on by a thread, some of them, to their livelihood for their children. The study in doctors, 1 in 5 doctors with long COVID can't work. And there's lots of headlines recently about the increase in people who are not able to look for work. So if you follow the pandemic from 2020 and the numbers of people not working, it does correlate with the increase in long COVID. Obviously, there's other reasons why people don't work, but I think because it's so prevalent in that age group, that it has a huge impact on employment. There will be elderly people with long COVID who never get diagnosed with it, because they will potentially get more forgetful, decline. I've seen it in my own patients in general practice, decline, and it looks like old age, but actually they've had COVID and never got better from that COVID. So they're probably not diagnosed, and what's interesting about long COVID is that with ME, you don't tend to get as many people up to about 50. It tends to hit people younger in life, sort of teenage years in their 20s. And with long COVID, it seems to affect a whole spectrum up to an older age than what I see with ME. But I suspect there's many not diagnosed in either side of those groups.
I just remind you, you've got 15 minutes left, Mrs.
Yes, thank you, Rogers. Just if I can take children and teenagers briefly. As we've established, you don't see patients under the age of 16, but obviously you do see patients who have had long COVID as a child and then graduated, as it were, to seeing you. And you do tell us that, paragraph 58, there's a lot of children that are told it's in their head, but they may have been in bed for a few years before you see them.
In bed, yeah, absolutely. And I've managed to give them peak treatment for POTS, got them out of bed, and got them back to some education or something that resembles a normal life.
And so far as recovery is concerned, I think you do indicate it at paragraph 102 and following that teenagers make the quickest recovery.
Yeah.
Can you identify a reason for that?
I don't know if it's to do with their physiology. So our bodies change as we get older, our immune systems change. But the most dramatic recoveries I've seen are teenagers who I have treated for POTS and dampened down their immune response, and they've had extraordinary recoveries. And they may have had no treatment for several years, and it seems such a waste that that treatment couldn't be instigated by any doctor several years before and save the suffering that they've had for those several years.
Briefly, you do and have produced for us a paper from the Lancet on outpatient treatment of COVID-19 and incidence of post-COVID-19 condition over 10 months. And reading very short from that, because we can look at it in detail. This was something that was produced in October last year, and the interpretation of the trial that was carried out was that outpatient treatment with metformin, which I think we all know is a drug normally associated with the treatment of diabetes. This reduced long COVID incidence by about 41%, with an absolute reduction of 41% compared with placebo. Metformin has clinical benefits when used as outpatient treatment for COVID-19 and is globally available, low cost and safe. Is metformin something you prescribe for some of your long COVID patients?
So this is more looking at prevention of long COVID. But at the moment, and it's been the same for the past 4 years, that we have a reactive style of responding to COVID. So if somebody gets COVID, it's essentially, in the beginning we're told wait until you're blue and then go to hospital. And still we don't have much treatment at the time of COVID. So if you get COVID and there's a drug here that may, probably needs some more work, but may reduce your risk of long COVID by nearly half, 50%, would that be something you might want to take? And at the moment, and there's going to be other drugs like that already exist, so that's why we do research studies. A very small percent of the population can have antivirals. They also reduce down the risk of long COVID. So what we're doing is we're letting people get long COVID, and then we're not treating it once they've got it when there is potentially preventable medication for them.
Thank you. I can bring your evidence to a close, Doctor. You've provided us with a section on what we need, and I think in our discussions, I think we've probably identified that most of these elements come with a cost in financial terms. But one of those that I do want to ask you about is what you say at paragraphs 143 and 144. And perhaps you just read those out, please.
Most of all, we need to stop telling people that it's psychological, because we have enough research to know it's a physiological illness. Education is important, so we need to stop telling people with long COVID that they need to just try harder or exercise to get better, because that is adding to stress on top of what they're already going through.
Dr. Taylor, thank you very much. Is there anything further that you would like to talk to us about?
I think I would just like to add that the risk of long COVID is still there, and the recent Canadian study suggested that by 3 infections, your risk of long COVID is 38%. What we don't want is a population full of people who are unwell like this, who are suffering, who can't work, who are losing their houses, and not aware that that risk is still there. So I think we need to do more work, and this especially applies to children, in schools, for example, of ventilating buildings to a standard whereby COVID is taken out of the air. We need to have people who are, obviously unwell with it, not attending school. The prevention of long COVID is really important, and I think the reporting of long COVID and the reporting of COVID, we should remember that it is still a dangerous virus, and although it's not killing people in the same numbers that it did before, it is primarily disabling people. And I think it's just worth that we are still aware of that, and there's a lot of work to be done aside from fixing patients that are already unwell to prevent more cases.
There's one point, I'm sorry, I should have asked you. It relates to a matter I discussed briefly with Mrs. Ormerod this morning.
Yeah.
We've heard from a number of both representatives and witnesses that post-viral syndrome of some description might have been anticipated with COVID. Do you have a view on that?
Yes, when I first heard about COVID early 2020, my first thought was, what's the case fatality rate? It's natural to wonder that. And then my second thought was, what are we going to do with all of the people who don't recover? Because the SARS-1 patients didn't have a good level of recovery. So I think we could have anticipated, not the exact number, which we think is around 10%, but on one infection, but there's some arguments either side of that. But I think absolutely we could have foreseen quite a lot of people who would be disabled by the virus.
Well, with that, Dr. Taylor, thank you very much.
Thank you.
Yes, indeed. Thank you, Dr.
Thank you,
Taylor.
Lord. Thank you.
And with that, we'll close it for the day.
Tomorrow, my lord.
And we'll be back at 9:45 tomorrow. And I think, no, it's not you. In fact,
I have a day off.
you have a day off. It's all right for some, isn't it? Thank you very much. Very good.